Okay. Senator Monning? No. Thank you very much. We will move on to panel issue 12. Again, this is an oversight issue. And we will be inviting Rick Rollins and Kristen Jacobson back to join us. I know, but we... Got it. I will do that. Got it. Got it. I got you. Yeah, I know. Again, we will hear from the department first, then Mr. Rollins, then Ms. Jacobson. And this is issue 12, page 35 of the agenda, insurance copays and deductibles. We'll hear from the
Thanks, Madam Chair. Jim Knight with the department. As noted in the agenda, the budget for fiscal year 13-14, including trailer bill language to allow regional centers to make health insurance copay and co-insurance payments under specified circumstances. That trailer bill language did, at that time, prevent the payment of health insurance deductibles. However, with the current budget for this fiscal year, trailer bill language was put into place to allow for payment of deductibles in addition to co-payments and co-insurance. While the majority of the expenditures so far have been associated with behavioral health treatment, other services or other medical services for which co-payments have been made include speech, occupational, and physical therapies. The budget for both the current year and for fiscal year 15-16 includes approximately $9.9 million to cover these costs. As the data suggests in the agenda, we're certainly well below that level at this point. One thing to note is that when we look at this point in time last year, we were at about the same level that we are now. So now for this year, it says that we're at about $800,000 in co-payments, co-insurance payments, or co-payment and co-insurance payments. Last year, at this time, at that point in time, we were at about $700,000. Currently, for last year, it's up to $3.2 million. The reason I bring that up as a comparison is because it's been reported that these payments take a lot longer to process and get up to us. So it's still going to take some time to know the full effect of where we are, certainly in the current year, especially with the deductibles, which is a new cost that the regional centers are paying for at this point. Mm-hmm. The other question I think you wanted is what savings can be associated with this program based on cost avoidance. Well, certainly we would expect that there is a general fund savings. We have not done the out-year projections to get a true estimate about what those would be.
I wanted to provide some clarification to the audience and all those who have a copy of the agenda. The chart on the bottom of page 35, the center column copay co-insurance. Under consumers, the second for the year 2014-15, you see it says the numeral 8. That number should be 871. Big difference. I see people are beginning to line up for public comment. That's fine. I am just going to suggest and ask your indulgence when we get there that I am going to ask any of the members of the public who are hearing impaired or deaf to go at the front of the line while we have translation services, because she may not be here for the entire public comment realm. Okay, so if folks who are hard of hearing or deaf intend to testify, we'll have them go first. Everybody in line heard me? Thank you very much. All right. Thank you very much, Department. We will move on with Mr. Rollins.
Thank you, Madam Chair. Rick Rollins, a legislative advocate for the Association of Regional Center Agencies. You have asked us to describe our perspective and experience on this issue. In 2011, ARCA was a proud co-sponsor of the Autism Insurance Mandate Bill, SB 946, by Senator Steinberg. And as a longtime parent advocate as well, I was personally involved and totally dedicated and committed to seeing SB 946 become a reality. This celebrated legislation provides broader access to critical transformational services to individuals with autism and other autism spectrum disorders that previously did not have access to them. It also allowed the state to realize significant savings as the cost of services was shifted from the state to private insurers. SB 946 did, however, have a very significant unintended consequence. Families with private insurance that had previously been accessing services free of cost through regional centers were suddenly faced with having to pay co-payments, co-insurance, and deductibles to access these services through their insurers. Trailer bill language in the year 2012 allowed regional centers to fund co-payments and co-insurance under certain circumstances, but prohibited the payment of deductibles, some of which were and are prohibitively high. In order to give their children access to these critical services, some families were forced to discontinue private insurance for them or simply stop the service altogether. A survey that was recently conducted by the Autism Society of California captured this fact in great detail. Last session, ARCA urged the legislature to address this issue by requiring regional centers to pay for co-insurance and co-payments, and was pleased to see in the 2014-2015 budget funding and policies put into place that would allow regional centers to fund deductibles for many families. The ability to fund deductibles began 8 months ago, so it's really too early to ascertain the full impact of this change. Nonetheless, ARCA is pleased that steps continue to be made to break down barriers to service access for people and the families that we serve. Thank you.
You did that on purpose, Mr. Rollins.
Oh, you want me to keep talking? No.
No, I'm okay. Thank you.
Sorry.
And Ms. Jacobson from the Autism Deserves Equal Coverage Foundation.
Hi, yes, Madam Chair, thank you for the opportunity to testify. I would definitely like to echo but not repeat the comments that Mr. Rollins made. One thing I do want to add is that SB 946 was clearly not intended to shift the cost of these services from regional centers to consumers. It was absolutely intended to shift it to private insurance, but that unintended consequence that Mr. Rollins talked about was not intended.
Right.
I do thank the legislature very much for having opened up deductibles. While there is not a lot of data about the impact of deductibles, I do think that there are some important pieces of information that we can glean even from the small number of cases that have been put through. The average cost per consumer is about $900. This is very much in line with what the Autism Society of California survey predicted. It's about half of the average deductible. So while we don't have an overall number of how many consumers will be taking advantage of this, because deductibles do tend to happen in the January through June timeframe as opposed to the second half of the year, I think the $900 per individual is a very realistic number. It's consistent with the autism survey. It's also consistent with the Healthcare Fund California report. And so in terms of, we don't need to be scared that as a system as a whole, it's going to be millions and millions of dollars. So I do think that very much it's possible to both cover the copays and the deductibles within the budget. But I think there's something that's important to note. There is still a pretty significant restriction on the 400% of federal poverty. So that means what really matters is which, who does your employer happen to be? If you happen to work for a large company that actually has strong benefits, but does happen to not cover behavioral health treatment, you have no share of cost. If you work for a small provider, as many low-income families do, you have a large share of cost. So there's a real disproportionate effect still between who happens to have the share of cost. And with the family participation, we just heard the same discussion about how much time and effort it takes, and sort of the relationship that's broken between the regional center and the family when all of a sudden, not only are you asking for, can I have your W-2? Can I have your rent? Why are you paying for internet service? Do you really need internet service? These are questions that have actually been asked to families in trying to determine whether they qualify for an exception for the 400% of poverty. There is more than enough money in the budget to cover copays and deductibles without any FPL. And in the same way that a $250 family participation is very meaningful and limits access, for the family that their deductible or copay happens to be $5,000 or $7,000, there is an extreme limitation on access to services. And the lower the income of the family, the higher the copay and the deductible. My copay and deductible is $500 for the year. Not a problem. But someone who's working at a minimum wage job, they might have a $10,000 deductible because they're working for a company that can't afford high-end insurance like my husband's company provides. So I guess our recommendation would be that you certainly continue the allowance. We support ARCA's original position that it should be required. It will take away the discretion, all the back and forth. We recommend that the 400% FPL restriction is removed, and also that careful consideration is made with the Medi-Cal transition, because Medi-Cal will start picking up some of the copays, but they're only going to pick it up to a certain level, and private insurance and Medi-Cal rates are different. And what we don't want to leave is the families holding a big hole and plugging the dam, which they needed to do when we were in a fiscal crisis, but they really don't need to do right now. And we want to make sure that that is left intact, and we restore this to something that affects every consumer equally, regardless of what kind of insurance they happen to have or who they happen to work for. Thank you very much.
Thank you, appreciate that. We'll move on to our final issue, lucky number 13. Issue number 13, page 37, and it's these two really go hand in hand because it's the behavioral health treatment, the governor's proposal. And we've got the same group of panelists, so we're going to start with the department, and from there go to finance.
Madam Chair, hi, Jim Knight again. As the agenda points out, the Department of Healthcare Services submitted a state plan amendment to cover behavioral health treatment for individuals with a diagnosis of autism. In a policy directive that was subsequently put out, those individuals who received those services as of September 14th through the regional centers will continue to receive those services through the regional centers until a transition plan is worked out between the Department of Healthcare Services and our department. And currently right now, that's about 8,800 individuals who are continuing to receive their services through the regional center. So for those individuals that sought behavioral services after September 14th, they are to be referred to Medi-Cal managed care plans to receive behavioral services. So the estimate right now for the current year is only addressing those individuals who would have received services through the regional center after September 14th. So it assumes that there's a reduction of $2 million for those individuals. The transition plan, one of the questions is how are we going to, coordinate the transition plan to make sure that everyone, people don't fall through the cracks. We do have the benefit of a little bit of time in this one, and so we are taking our time to, one, learn from some other transitions that have taken place recently. One, as others have mentioned, the transition of services as a result of SB 946 and the like. We're consulting with not only regional centers but others to try and learn what worked well and what didn't work so well in those transitions to try and see if we can avoid some of the pitfalls perhaps there. We have been meeting regularly with the Department of Healthcare Services to lay some of the groundwork for that transition. Most of the work so far has been related to identifying who's receiving services now, the providers, and also the rates. Healthcare Services needs to do a lot of work with that, obviously, to establish rates to build up the provider network, and because the providers also need to know what the rules are as well. We have also recently coordinated a call with just regional center representatives with the Department of Healthcare Services to go over specific issues that are applied to the regional centers. We had representatives from, I believe, 20 of the 21 on. All of them reported that they have already had good coordination with their local managed care plans and had been working together very well in this area to date. So they so far have not reported any issues with that so far. And so not only do the regional centers have contacts with the local managed care plans, we have also provided the managed care plans with the reciprocal contacts at each regional center as well. So we're going to continue to work with the Department of Healthcare Services and the stakeholders to develop that plan, and so that we can ensure the transfer of services is well thought out. Thanks.
Thank you. Mr. Rollins.
Thank you, Madam Chair. Once again, the background and related issues on this subject are nicely laid out for you in your analysis. The Department of Healthcare Services, DHCS, has engaged in a robust stakeholder process on this issue and should be commended for its efforts to expand service access while ensuring that children who are already receiving these critical services through the regional centers do not have a lapse in services. As Medi-Cal begins the process of funding BHT, ARCA is encouraged from the guidance from DHCS that indicates that Medi-Cal eligible individuals receiving behavioral services from regional centers will continue to do so until a transition plan is developed by DHCS and the Department of Developmental Services. ARCA understands that for regional center eligible children in fee-for-service Medi-Cal, BHC services will continue to be administered by the regional centers. DHCS will reimburse DDS for costs associated with this benefit. Similar to the administrative costs that health plans are paid to coordinate, monitor, and administer benefits, the true cost of providing these services must include the cost of regional center coordination and administration of the benefit, in addition to the actual fees paid to behavioral health providers. For other Medi-Cal benefits, regional centers are not expected to fulfill this role. In light of the existing inability to comply with federally mandated caseload ratios, regional centers will be unable to coordinate this benefit without additional funding to compensate them for the costs associated with coordinating and monitoring these services. In order to ensure smooth transition of funding and services, ARCA and the regional centers look forward to working as active partners with DHCS, DDS, individual health plans, families, and advocates. Regional centers bring a wealth of clinical experience to the treatment of autism. It is essential that clinical judgment, best practices, and sustainability are in the forefront of any decisions about future service deliveries that are made. We hope to learn from our experience with the implementation of SB 946, and we're looking forward to working with all stakeholders as we roll out this program. Thank you.
Thank you, sir. And we'll close with Ms. Jacobson.
Thank you again, Honorable Chair. I want to open by concurring with Mr. Rollins' comments about how appropriate it has been to delay the transition, to get services immediately to the kids who were not receiving services, but delay the transition for the regional center children until a very comprehensive plan is addressed. And there are many good things that have been happening about the transition. Although I feel like my role here today is to make sure that you are aware of the things and the challenges that are happening for families, as I'm representing families who are trying to access these services. While there is a clear understanding among the leadership that the regional center transition is delayed, it does not seem that there is a clear communication down through the regional centers, through all the caseworkers to the consumers, because we are routinely hearing from consumers who have been told by a regional center caseworker or somebody that they need to transition now, or that the authorizations are being changed. Now we're only authorizing 3 months at a time instead of 6 months because the transition is coming, and yet DHCS has been very clear that there is no transition timeline yet, because they are properly taking a very reasoned and measured approach to setting it up. But I think there really needs to be some work on the communication, because it may just be an individual caseworker who's misunderstanding and giving the wrong information, but you know, that family, if they don't happen to find me or one of 2 or 3 other advocates in the state, is just given improper information.
Right.
There's a group of people that are falling through the cracks. They are people who were in the regional center system before September 15th, but were not receiving services.
Yeah.
Where do those people go? They are still being ping-ponged. We seem to have finally gotten an answer that they are supposed to go to Medi-Cal, but I have a concern if someone spent 60 to 110 days maybe going through the regional center assessment and evaluation process to determine an IPP and then is sent to Medi-Cal to start over again. Medi-Cal in many areas does not have assessment programs. Some of them are taking regional center assessments. Some of them are requiring new assessments. You have a group of kids that is stuck, and these are kids that were already identified as needing services. So they're some of your highest need kids. So we need to make sure, frankly, I think if they've been started with the regional center, they should be finishing with the regional center, so you're not transitioning someone mid-assessment. But either way, someone needs to do something with those children because they need to be served. There's a time frame issue. A lot of or several managed care plans are using the regional centers to do the assessments. There is an obligation of the regional centers to do the assessments. However, the timeframes of the regional center is to have the IPP within 120 days. The Medi-Cal requirement is they need to have appointments for assessment between 10 days if it's considered mental health or 15 if it's considered specialty. Regional centers are given extra time because of the paucity of assessments and the need to be able to fit people in. That is not, it's not leeway that Medi-Cal has. And so there are kids who are not getting their Medi-Cal timelines met. And also there are going to be regional centers that are trying to figure out, what do I do to meet a Medi-Cal timeframe? I'm supposed to do this within, 15 to 30 days. And so do I have to cut the line for someone who's not a Medi-Cal? Medi-Cal really needs to figure out the assessment, and the relationship of how Medi-Cal and the regional centers are working needs to make sure that the timelines are met. These are not optional timelines. And the eligibility criteria are not the same. So we need to make sure that the regional center who are doing Medi-Cal assessments are doing Medi-Cal eligibility, which means any medically necessary services identified in a screening needs to be provided. They don't need to be regional center eligible. In fact, the biggest part of this benefit was for families who weren't going to be regional center eligible. So, that is an issue that's very tricky. The transition planning is critical. Services need to stay on an IPP or IFSP, even if Medi-Cal, the generic service, is paying for it. When families are coming in after September 15th, they're being sent straight to Medi-Cal, and it's almost like they're skipping the process in some of the regional centers to go through. And the regional center may not pay for that service, but it should be on the IPP. It should be involved in the care coordination because it's something that's going to meet the needs of that individual under their IPP. There are going to be big continuity of care issues on the transition. That was probably the biggest thing we saw with the SB 946 transition. Certain places, Kaiser's a good example, they primarily use Easter seals. That is not a vendor for the vast majority of regional centers. So almost every single child who's on Kaiser has to switch from their regional center provider to Easter seals. Similarly, you've got 8 or 9 or 10 county plans that are exclusively contracting on the BHT side with one provider, and that provider is not a regional center provider. So you're then going to have thousands. We're talking SB 946 transition with all its difficulties was about 800 kids, or maybe even 680 kids. I can't remember which one. This is 7,700 kids. This is a huge order of magnitude different. And I think it should be really seriously looked at whether we're getting the federal match for Medicaid in the regional center. We're getting it from Medicaid. These are Medicaid services. There may be some way behind the scenes to do the accounting that does not involve transitioning 7,700 kids and changing vendors. I think it's something that should be looked at. It obviously needs to be staged. LA is transitioning 1,800 kids. I think one thing is it needs significantly more formal consumer and consumer representative participation in the process. I'm very pleased that DDS has been meeting with DHCS regularly on this issue. Consumers have not been participating in that detailed process. We have the monthly stakeholder meetings. I think DDS has been interested in conferring with us, but there's something going on in the process between we're not able to get involved in a formal way in that process. We're being told we're not even allowed to from DHCS. It's critical that families are involved in that process because we have the experience of having been transitioned, that and for the healthy families. Continuity of care was completely lost from healthy families because the new HMO was not even allowed to talk to the family until they were already started.
Right.
And the other one was already done, and so there couldn't be continuity of care. Continuity of care says up to 12 months, but it's at the discretion of the health plan. They could do a month or a week. Continuity of care needs to be a minimum of 12 months. So my recommendation would be to include a formal stakeholder consumer process in the transition. Also include stakeholders in the communication plan, make sure the services stay on the IPP, and then ensure the continuity of care minimum of 12 months. I would suggest oversight by this committee of this process. I think it would be very helpful. This committee does have a DHCS panel on this topic in April. And the last thing is I think someone needs to research a huge discrepancy that was identified when we figured out the number of people transitioning. LA has 1,800. Some counties have 1. Why do those counties have no one receiving BHT services right now? I presented for families last year, 5 people on Medi-Cal said they didn't have any services. All of them are regional center families. None of them were getting services, so someone needs to look into that. Thank you, and I hope I didn't go too far over.
I appreciate that very much. I would just follow up very quickly with the department. As you talk about, new kids are being served under Medi-Cal, we're going to look at the transition. What will be your process for identifying barriers to the transition? I'm hoping that you'll use kind of the new admissions, for lack of a better term, as to some degree a learning ground, but how will you identify barriers, particularly with limited to no stakeholder, provider, consumer involvement?
Yes, Madam Chair, you're right. Certainly, we will be learning from what's going on now with the new individuals receiving services through the under Medi-Cal, and we will be working with stakeholders. It's one of the things that we, at least from our perspective, is that we have to do that in order to get it right. We need to learn from what happened before and get people's expectations or manage the expectations, if you will, and learn from what the concerns are so that we can do it well.
And so there's no barrier to stakeholder participation, is there, sir?
Not to our knowledge.
Okay.
And then the other part of it is the spirit of not only the enthusiasm of the speaker, who I know pretty well, and her tenacity. She will follow up with all of us anyway.
Yeah, and me too, so
yes, I know.
handle it.
And that's what I was going to say. But even though if you're item number 13, it's still very important. So,
Yes, that's true.
Okay.
That's true.
I have one other small thing that the chair might consider.
Please.
Just for the record, Rashi, who you recognized earlier.
Yes.
We've been very fortunate on public policy issues relative to our clientele, have excellent service from both the Department of Finance and the LAO. And when somebody who has just contributed so much great information deserves that 30 seconds, as you already gave her, and 30 seconds more for her great service.
And here's your 30 seconds.
Thank you. Thank you, everyone, very much. I really appreciate it.
Wonderful. Okay, thank you to the panel. With that, with the 5th hour of the hearing having arrived, it's the best part, public comment. So let me tell you what I'm going to suggest that we do to honor everyone's time, both the providers, consumers, advocates who have traveled to be here today. I want you to have your opportunity to share your concerns, but I'm also going to ask you to exhibit some discipline, some self-discipline. We sprinkled advocates, providers, consumers throughout the panel to give them an opportunity to have a full, in-depth conversation about the various issues by panel. And so I hope that you will feel free to use the term ditto, that you you support what's previously been said, because everyone is going to get a maximum of 2 minutes. So looking at the approximately 40 people in line, you can do the math, right? 40 times 2. I'm going to really cut you off at 2 minutes, because as the first group of public testimony witnesses exhibited perfectly, you can make meaningful, profound statements under 2 minutes. Trust me, you really can. Fair enough? Fair enough. You want them to fill it out? No. I think if they sit down, they can want another 2 minutes. It's something about when you settle in, you talk, you stand in there, 2 minutes. So we were going to start with our hearing impaired consumers and providers who were here, because I'm not sure how long we will continue to have translation services, so I wanted to make sure that they were a part of the dialogue. In case we lose our support, we will have covered them up front. With that, first witness.
Hello, my name is Deslyn Malone, and I've been working in this field for 20 years. And since day one, nothing has changed. We're training staff. We're always looking and hiring new staff because staff aren't getting paid enough. Oftentimes during the weekends, during the week, we have to have staff work 2 to 1, 3 to 1 because we're short-staffed, and they're not getting paid fully what they're worth. Sometimes families object because they don't feel that they're getting the quality services and supports that their children deserve, and I feel for them. I feel for the family members, and so I would hope you would consider the 10% increase.
Thank you.
Thank you.
Next witness, please.